I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the land I'm working on today at the UNSW Randwick campus. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across the country. We pay our respects to elders past and present and extend that respect to any First Nations people joining the webinar today. Now, it's my absolute pleasure to introduce today's speaker, Delyse Hutchinson. Delyse is an associate professor in the Centre for Social and Early Emotional Development in the School of Psychology at Deakin University. She also holds an adjunct position at NDARC, and she is also a practicing clinical psychologist. Delyse's major research interest is in understanding the developmental origins of mental and behavioural disorders. In today's webinar, Delyse will be presenting findings from her program of work on the impacts of parental substance use in the perinatal period on child development. As our expert panelist today, we're lucky to have Dr. Natasha Reid from the Child Health Research Centre at the University of Queensland. Natasha has both research and clinical expertise relating to alcohol and other drug use in the prenatal period and the prevention, assessment, diagnosis and treatment of fetal alcohol spectrum disorder. Delyse and Natasha will take questions from the audience after Delyse's presentation, and you can log questions for them in the Q&A function at the bottom of your Zoom screen. So with no further ado, I'm going to hand over to you now, Delyse.
Okay, I'm just going to get my screen in the right position here. Hopefully that's going to work okay. Well, thank you so much for the introduction and good afternoon, everyone. I did just want to mention this upcoming workshop at the APSAD conference in November for anyone interested in perinatal substance use. There's a link to the conference website if you'd like to find out more. Okay, so today I'm presenting on the topic of substance use in parents during the perinatal period and child development. I'll be presenting data from multiple Australian cohort studies looking at alcohol, tobacco, and cannabis use perinatally, and how the results of these studies can inform prevention and intervention. I had planned to also include some results from our systematic review hub on perinatal substance use, but we're currently finalising those analyses, so stay tuned for another presentation on those findings to come. So before I begin, I did just want to thank Dr. Alice Harvard for inviting me to present as part of the NDARC webinar series, Dr. Natasha Reid as well for giving her valuable time today to participate in the webinar. And I'd also like to acknowledge my many colleagues who've contributed to this research. So my talk today is focused on 3 areas. These include alcohol in pregnancy, and I'm going to talk about patterns of alcohol use around pregnancy, including some data on our partners, as well as covering some predictors of alcohol use. Then I'm going to talk a little bit about cannabis and tobacco use prevalence in pregnancy and their associations with infant birth outcomes. And finally, I'll touch briefly on the implications of these different bodies of research for prevention and intervention. I did just want to run through a couple of key terms because there's a lot of terminology in the perinatal field. So perinatal itself is really an umbrella term that refers to the period around childbirth, so spanning both pregnancy and the postpartum periods. Preconception refers to the 3 months prior to conception. A term that's really important in today's presentation is periconception, which you may not be as familiar with. This refers to the period between conception and the awareness of a pregnancy. So often this is around the time from conception to about 6 to 9 weeks of pregnancy when a woman typically becomes aware that she's pregnant. And postpartum refers to the period after birth, which it can extend anywhere from around 8 weeks post-birth through to 2 years of age. Today, I will, however, mainly be focusing on preconception, periconception, and pregnancy. So, preventing alcohol use in pregnancy, what does the latest Australian cohort research tell us? By way of background, we know that fetal growth and development are exponential across pregnancy into the early childhood years. Indeed, they are much more rapid during these periods than at any other time in life. Now, this image, just hover around this period, shows how the brain develops from pregnancy through to adulthood, age 25 years. And what we can see that around the time a child is born, so it's around this period here, the brain has already developed to weigh around 30% of its adult value. And by 5 years of age, we can see that it actually weighs 90% of its maximum adult value. So early life is a really critical period in terms of rapid development. And it's often referred to as a critical period of vulnerability, where exposure to substances such as alcohol, as well as cannabis and tobacco, which I'll talk about later, can have significant impacts on later development. Importantly, very early in the development of the child, there's already a lot happening. So I want to just point that out because it's a very important point in today's presentation. So it's well documented that alcohol exposure can have negative impacts on offspring cognition, language, motor, social, emotional, and behavioural outcomes, with heavier and more frequent alcohol use associated with higher levels of harm. This can include fetal alcohol spectrum disorders, which are characterised by really significant physical, neurocognitive, and developmental impairment. And this can have really lifelong adverse impacts. Public health recommendations currently advise to prevent harm from alcohol to their unborn child, women who are pregnant or planning a pregnancy should not drink alcohol. Despite this recommendation, around 1 in 4 pregnant women in Australia, that's around 20% of pregnant women, report consuming alcohol. And the prevalence of FASD is estimated to be between 1 and 2% in Australia, but is much higher in some high-risk communities. So alcohol remains a significant issue of concern. So moving to the cohort studies I want to talk about today, I'm going to cover a couple of topics. First, I will be presenting data on patterns of maternal drinking in pregnancy with a focus on periconception drinking patterns, so that those early weeks of pregnancy. I'll also talk about patterns of drinking in fathers briefly, and then I'll present longitudinal data on drinking patterns in adolescent and young adulthood and their relationship with pregnancy drinking. So I'm going to use data today, talk about data today from 3 different studies. So these are all Australian longitudinal studies that have followed parents and offspring across their development. The Triple B pregnancy study is a study that I currently lead, which was established in 2009 at the University of New South Wales at NDARC, also with the National Drug Research Institute at Curtin University. The primary aim of this study is to examine the effects of substance use on child development. We recruited around 1,600 families, including the mother, the partner, where they were willing to participate, and also the child when they were born. And we took really detailed assessments of substance use, including alcohol, across the perinatal period. The Victorian Intergenerational Health Cohort Study was established at the Royal Children's Hospital in Victoria and is a 20-year intergenerational cohort study which has assessed patterns of alcohol use through adolescence and young adulthood into the pregnancy period. And I refer to this as VIX. Similarly, the Australian Temperament Project Generation 3 study was set up at the Royal Children's Hospital in Victoria and has been running now for over 35 years, with prospective data on alcohol use over an extensive period of time, including the mother's adolescent and young adult years and into the pregnancy period. And it is important to note here that prospective data on alcohol use over such extensive periods of time are really rare, so they do provide rigorous insights into patterns and predictors of alcohol use in pregnancy. I'm going to start by talking a little bit about the frequency of alcohol use in 2 of these cohorts. This is from a paper published in Psychological Medicine with the Intergenerational Cohorts Consortium, where we looked at alcohol use in VIX and ATP-G3. So this is some basic frequency data looking at the frequency of alcohol use prior to pregnancy awareness, so in that periconception period, after pregnancy awareness and at 1 year postpartum. And we're looking here both at the individual cohorts and then aggregated the 2 studies combined. And there's 2 points to take away from this. I think the main one really is that we can see that a lot of women are actually using alcohol prior to pregnancy awareness. The aggregate frequency is 76%. Now, this drops down considerably after women become aware of their pregnancy to 18%. We also see 1 year postpartum a resumption of alcohol use among many women who have stopped or reduced their drinking back to 77%. So most women are resuming drinking after 1 year. Now, this paper was published in Addiction, looking at, here we're really looking at patterns of drinking as opposed to just overall frequency of drinking. So we're focusing on frequent drinking and binge drinking patterns in early pregnancy. There's quite a lot in this table, but I'll talk you through the key points. So here we're looking at the VIC study, and we're looking in greater detail at maternal patterns of alcohol use in preconception and through the pregnancy period. This table shows that the frequency and quantity of alcohol changes again across the pre-pregnancy awareness and into the pregnancy recognition period. So we can see a marked decrease in drinking after women become aware of their pregnancy. Both frequent and binge drinking reduced from around 17% to around 0 to 1% after pregnancy awareness. And most women were very quickly reducing their alcohol use. But it does highlight the importance of the periconception period in regard to alcohol risk exposure. Then what we can see is from preconception, so I'm going to use my pointer here, around here, into, so this is age 29 years, I should point out, through to early pregnancy, the actual proportion of women who are both drinking frequently and binge drinking is quite stable. So around 17% drank alcohol 3 or more times a week, and a similar proportion reported binge drinking across both time points. So this suggests that women drinking at these levels are less likely to change their drinking patterns in early pregnancy. Finally, we can also see when we look into the third trimester that around 12% of women continue to drink after pregnancy awareness. So there is still a proportion of women who are drinking once they become aware of their pregnancy. And this increased to about 19% in trimester 3. So the next set of data I'm presenting on is from the Triple B study, which assessed alcohol in detail across multiple time points perinatally and in partners. Okay, so we found a couple of things here, which I'll just talk you through. So first of all, we can see that whilst women reduce their alcohol consumption after pregnancy awareness, low-level drinking actually remained quite frequent across the pregnancy period. So around 20 to 25% of women continued to drink alcohol across the pregnancy period at low levels. What we also observed was higher risk patterns of drinking were most evident in early pregnancy, with around 17% reporting binge drinking and around 14% reporting heavy drinking. So relatively similar to what we saw in the VIC study with frequent and binge drinking. We also looked at partners in our study. We weren't able to look during the course of pregnancy, but in trimester 3, during preconception and early pregnancy, but we did ask partners in trimester 3 to report on the entire pregnancy period of their partner. And during this period, 84% of partners drank alcohol, so quite high rates of general alcohol use. We did find that the most common pattern of drinking was binge drinking, with 31% of partners reporting binge drinking during their partner's pregnancy. But also low, moderate and heavy drinking were relatively common in the sample as well. So partners were drinking fairly frequently during their own partner's pregnancy. So pregnancy drinking across the 3 cohorts, what have we found? So just to summarise, we found that around 76% of women reported a continuation of alcohol use into the early weeks of pregnancy. This represents an important target group for prevention, that many women are continuing to drink in early pregnancy. We also found that around 20% of women continued to drink throughout their pregnancy. So on pregnancy awareness, they didn't stop drinking as many other women did. They continued to drink. And additionally to this, we found that alcohol use remained common among partners as well during the pregnancy period. Okay. So next I'm going to talk about some data we looked at where we're wanting to understand more about the extent to which histories of alcohol use in the mothers might predict early pregnancy drinking. And we were particularly interested in looking at frequent and binge drinking. I'm just going to talk you through these results rather than put up tables of statistics, because it's a little bit easier to follow, I think. We found fairly consistent results here, both across frequent and binge drinking. So frequent drinking, 3 or more days per week in young adulthood here, predicted a 30-fold increase in the odds of drinking frequently in early pregnancy. We also found that the continuity of frequent drinking across the 20 years prior to conception, so from adolescence into young adulthood, predicted a similar trend, a 24-fold increase in the odds of drinking in early pregnancy. For binge drinking, again, we found that young adult binge drinking was actually very common, perhaps not surprisingly, and it predicted a 6-fold increase in the odds of periconceptional drinking. Once again, continuity of drinking across the 20 years prior to conception, from adolescence into young adulthood, predicted periconceptional drinking with a 3-fold increase in risk. So very consistent, strong relationships between maternal histories of alcohol use prior to pregnancy. So to summarise what these studies tell us about alcohol, first, alcohol use remains common during pregnancy in Australia, particularly during the periconception period, when women are also likely to drink at high levels. This really highlights a period of significant risk in terms of pregnancy drinking. Partner drinking is also common in early pregnancy and is likely to play a role in influencing women's drinking choices during pregnancy. Women who report risky drinking patterns in young adulthood and across adolescence and young adulthood are considerably more likely to also report frequent and binge drinking in pregnancy. And these results underscore the importance of strengthening prevention and public health messages about the need to reduce or avoid alcohol where there is the likelihood of a pregnancy. So next, I'm going to move to work we've recently done on tobacco and cannabis use among parents during the perinatal period and the relationship with infant birth outcomes. We've got 2 studies under review on this topic currently, but I'm going to present them. The methods are very similar, so I'm going to present them as sort of one bigger piece of work. So a little bit of background, just focusing on tobacco first. Over the past decade, smoking cessation initiatives have resulted in a really substantial drop in rates of maternal smoking. However, smoking in pregnancy remains the leading preventable cause of ill health for both a mother and her child. While studies differ in rates of prevalence, a recent review of the international literature suggests that 21% of women continued to smoke globally, that is. Interestingly, this review found that the highest prevalence rates were in high-income countries, such as the United Kingdom, the United States and Australia, with Australia having a prevalence of 9.6%. Now, this is concerning, of course, because we do know that maternal tobacco use in pregnancy is associated with adverse outcomes. There is a substantial literature on this, and these can include birth defects, preterm birth, stillbirth and perinatal death, as well as childhood disability. To date, however, limited literature has explored tobacco smoking in the preconception and periconception periods, which might inform earlier intervention, as well as the fact that relatively limited work has been done on this topic in fathers. So a lot of longitudinal studies don't include fathers, so this is an area that we were keen to explore. In regard to cannabis, we again know that cannabis exposure during pregnancy is also associated with a range of adverse outcomes, both to mother and offspring. Around 2 to 5% of pregnant women in Australia use cannabis during pregnancy. Estimates do vary somewhat. So it's not as common as tobacco, but the harms can be very significant. There are more limited longitudinal studies that have looked at the exposure effects across the perinatal period, and once again, fewer studies on preconception and periconception exposure. And cannabis is a really important substance to understand in regard to pregnancy because, as many of you will no doubt be aware, there have been recent legislative changes around cannabis towards legalisation and decriminalisation across the globe. And if I just jump forward a slide, you can see here, and this is probably already out of date now because changes are happening so quickly, but just as a guide, the green countries are where cannabis is legal. The purple countries where cannabis, there's a mixed status. So, for instance, medicinal cannabis might be accessible, but recreational cannabis is prohibited. And the pink countries are those where cannabis remains illegal. So evidence from countries such as the US, where we're seeing changes in the availability of cannabis, do suggest that there has been an increase in the frequency of young adult cannabis use. Now, why is this concerning? It's concerning because this coincides with the transition into the peak childbearing years in the late 20s through to the early 30s. So this may have some carryover into pregnancy, given what we're seeing with alcohol around the common patterns between preconception into early pregnancy. I haven't seen any data available on this, but it's a concern. So these two studies are really focused around understanding both the frequency of tobacco and cannabis use in the perinatal period, but also their associations with infant birth outcomes. The measures, as I said, are pretty similar in the design. We looked at any use of tobacco, any use of cannabis, and we also looked at weekly use of cannabis. We looked at these patterns across the perinatal period. For cannabis, given the frequency of use was a little lower, we did need to look at pregnancy as a kind of a holistic period from trimester 1 to trimester 3. And for fathers, we looked at preconception, substance use, and then we looked at whole of pregnancy substance use. So that was for tobacco and cannabis. Our infant birth outcomes were from hospital birth records, and we looked at admission to neonatal intensive care unit, small size for gestational age, small head circumference, low birth weight, and prematurity. We did adjust for a range of sociodemographic factors that are associated with tobacco and cannabis use. And we also adjusted for tobacco use in our cannabis analyses because a lot of people who use cannabis choose to smoke cannabis with tobacco. And we also adjusted for alcohol use in both sets of analyses. I did want to point out the nature of the Triple B sample. We do have to consider the sociodemographics of the sample. It is a middle class sample, tending towards a higher SES sample. So parents have relatively good education. Mothers were between 30 to 35 years and fathers were typically above 36 or older. So we'll talk a little bit more about the sample characteristics later and why they're important. So again, there's lots of numbers here, but I'll just draw your attention to the key findings. This is looking at the frequency of tobacco use perinatally. So we're looking at preconception, periconception into pregnancy. So most of the cohort didn't smoke tobacco, which is what we would have expected. We found that around 20% were smoking at preconception, and that decreased just slightly to 18% in early pregnancy. So there was a small reduction there. And then that halved to around 8% across the remainder of pregnancy. So again, once women became aware of their pregnancy, they significantly reduced their tobacco use. For men, there was very little change across the period. We had 24% of men continuing to smoke tobacco across the perinatal period. Again, lots of numbers here, but I'm really going to just draw your attention to the ones that are highlighted. When we looked at the relationship between any tobacco use and infant birth outcomes, most notably, we found we found an increased odds of admission to special care, which was associated with maternal tobacco use at all perinatal time points, with the strength of this relationship increasing across the perinatal period. And this is quite likely due to the continuity of exposure to tobacco that we saw an increased likelihood as the pregnancy progressed. Pregnancy tobacco use was also associated with increased odds of small size for gestational age, low birth weight, and prematurity, which we can see here. Turning to cannabis use, this is looking at any cannabis use in mothers during the perinatal period. And we can see that around 6% of women use cannabis prior to pregnancy, 5% in early pregnancy, so a small change, reducing to 3.5% in pregnancy. Among fathers, there was again very little change in cannabis use frequency. Around 9% of men use cannabis across the perinatal period. We also looked at weekly use. Essentially, rates of weekly use were slightly lower, as we might expect, but a similar pattern to any use. Now, looking to our birth outcomes, this is looking at any cannabis use and infant birth outcomes. What we found was that periconception and pregnancy cannabis use were associated with an increased odds of small for gestational age, small head circumference, and low birth weight. We also found that preconception associations were evident for small head circumference. This is now looking at weekly maternal cannabis use. The associations here were similar but stronger, as we might expect. So preconception, periconception, and pregnancy cannabis use were all associated with increased odds of small for gestational age, small head circumference, and low birth weight. Now, I haven't put up the data for fathers just because it's lots of numbers, but I can tell you the outcome. Essentially, we didn't find any evidence of adverse effects associated with either paternal tobacco use or cannabis use, either in preconception or during pregnancy. And whilst we had expected we may find some associations, I guess one conclusion is that there's no effects. There are some possible other explanations, though. And I mentioned about the sample before. It's important to note with the father sample that not all fathers chose to participate in the study. We had data on around 700-800 fathers, so quite a big sample. But having said that, the fathers that elected not to participate tended to be fathers who were more likely to use substance use based on data we obtained from mothers. They tended to be fathers who might have been more at risk of a range of different mental health and other kinds of factors, lower sociodemographic, etc. So as a result, the sample of fathers is biased more towards being advantaged. So we do have to keep that in mind when interpreting this result. The other thing that is important to note that given that the sample of fathers was somewhat more educated and aware of the risks of passive smoking, both smoking tobacco and cannabis, it's likely that if they were smoking either of those substances, they were probably doing it, making an assumption here, but likely to be doing it away from the mother. So that, I guess, is a more protective effect and may not have a direct effect via passive smoking on the infant. So further research is really needed on more diverse samples of fathers. So just to summarise what we found on tobacco and cannabis, perinatal tobacco and cannabis use in women was associated with adverse infant birth outcomes, a range of different outcomes, but we didn't find associations among fathers. Pregnancy exposure was associated with the greatest risk of adverse outcomes, but we did also see some effects in preconception and periconception. We think this likely represents a continuity of exposure over the perinatal period. So infants were being more exposed across the pregnancy period. So we would expect that effects would be greater in the latter part of pregnancy. More frequent use of cannabis was associated with greater odds of adverse outcomes. And the continuity of use from preconception into early pregnancy was again evident in our frequency data, highlighting that early period of pregnancy as a period of risk exposure. So moving now to our implications. I think there's a couple of points I wanted to make here, which are, I guess, more broad-based points around thinking on prevention and intervention in this space. So to summarise, we found that the patterns and predictors of substance use across the studies were remarkably consistent with respect to alcohol, tobacco and cannabis use. I mean, these studies were collected in, different states across the country, not all at the same time, and yet we find very similar results. So I think they're a robust set of findings in that regard. Our cohort data do suggest that there are some distinct groups of women who may need to be approached in different ways and potentially at different times. So we saw women who continued to use substances into early pregnancy, but then reduced or ceased use on pregnancy awareness, comprised a fairly large group within our cohort studies. And then perhaps a smaller group, but certainly a group that were there across all the studies as well, are the women who maintained their use after pregnancy awareness. That's not to say they didn't reduce their use, but they did maintain some use. So the longitudinal associations identified in our cohort studies really underscore, I think, the importance of a life course approach to prevention and early intervention. So it's not going to be as simple as targeting pregnant women or targeting women about to have a baby. It really needs to be more of a broad-based, integrated life course approach. And in saying that, I do acknowledge that there is already a lot of great work out there targeting many of these different time points. So it's not to say this work isn't already out there, but I think if we can think about it more holistically and in an integrated way across these different life course periods, we may get better bang for our buck in terms of investments in prevention and early intervention, as well as clinical treatment. So I guess, how do we target each of these time points? Thinking about adolescence, I think the work that's already being done is important to continue around prevention messaging to delay, where possible, the onset of substance use, and following initiation to reduce the risk of harmful substance use patterns through the adolescent period and into young adulthood. During young adulthood, as adults approach the childbearing years, pregnancy and family planning messaging is really important. Young adulthood is obviously the time where we see those patterns have been established that continue into early pregnancy. So if we can intervene there to modify patterns prior to pregnancy, that would be a really great outcome. Continuing support from GPs and health providers during this period is important, as well as accurate information on the risks associated with pregnancy exposure. And importantly, of course, clinical support for adults who are consuming substances at higher risk levels. Antenatally, I mean, we have some great programs and support in place through our hospitals and GPs, but I think this is important to continue, as is the dissemination of accurate information about the risks of substance use in pregnancy, because there is a lot of misinformation that is provided to women. And postpartum, although I haven't touched on this as much during my presentation, I think that this is also a time of risk, because we saw that resumption to pre-pregnancy levels of alcohol use in one of the earlier slides that I showed you, and we have had other studies also show this finding. So I think support around that transition from having a baby to being a parent is important, including support around breastfeeding and I guess a harm minimisation approach to substance use for those wanting to return to using substances. Okay, now the other point I really wanted to make is that it's not just about women. We know that the woman's carrying the baby, but this is not just a woman's responsibility. Women don't exist in a vacuum, and it isn't I have talked a lot about supporting women through my presentation, but by that I don't just mean that a woman has to change her behaviour in and of herself. From a prevention perspective, and I'm not an intervention scientist as such, but I do think it is really important to think about the social ecology that surrounds the woman and the child to be. And what I mean by that are the different levels within the environment that inevitably influence our decisions around behaviour. So here we might think about partners, for example. We saw the partners are also using substances a lot during their partner's pregnancy. So they may well be influencing inadvertently a woman's choice around substance use, immediate family, community, and so forth. So I think it's important to say that we want to support women, but we want to do that by not just targeting women, but also thinking about the ecology around a woman. And this can differ, obviously, for women in different communities. And an example of this, just to give you an idea of what I'm talking about, that has been rolled out and was quite an effective campaign, I think, in its messaging, was the Pregnancy Pause campaign. And this was one where partners and loved ones were encouraged to reduce or cease alcohol use for a period while their wife or daughter or friend were having a baby, so to join them in not drinking. So this is the kind of thing I'm talking about, really, about how can we support a woman without just expecting her to make a change. Okay, so I want to finish up there. And before I do, I just once again do want to acknowledge specifically some of my research team and collaborators over the years, and I'm sure there's many more. But these are some of the people who've contributed to the papers and research I presented today. I'd also like to very much thank our participants who are so amazing and who stay with us for many years. And it's quite incredible, the Temperament Project of 35 years, actually I think it's 36 years now, that they've had participants continuing to be involved in their research. So very big thank you to the participants, as well as our research teams over many years, our collaborators and our funders for this really important body of work. I will throw to question time, but just a final reminder for anyone who found today's presentation interesting that we'd love you to come along to the perinatal substance exposures workshop. If you're planning to attend APSAD or happen to be in Canberra, we'd love to see you there in November. Thank you very much.
Thanks, Delyse. Gosh, that was a really fascinating and important presentation. And as a self-confessed data nerd working in the perinatal substance use space, I'm highly jealous of the fact that you've got such rich data, as well as it being really large scale. It's yeah, really amazing what you can do with it. So thank you for sharing your insights from it, and welcome, Natasha. Thank you for popping on. Before we get to your reflections, Natasha, I just want to let the audience know we are taking questions in the Q&A. We've got a few there, which we will get to, but you've got a couple of minutes now to add more, while I'll ask Natasha to share some of her insights and reflections on the work that Delyse has just presented.
Sure. Hopefully you can hear me well. Firstly, fabulous talk, Delyse. Lovely work. I love everything that you do and really appreciate all the wonderful research that you've been doing. So I guess the first thing that I just wanted to touch on is, I think I love how you talked about us to have this need for a life course approach. I think it's so important to really think about preconception, but also, as you discussed, adolescent and young adult alcohol use and how that can also lead into the pregnancy period. And also the importance of that social ecological approach, and how you discuss partner alcohol use and the relationship to prenatal alcohol use as well. Because I think for prevention to be really effective, we really have to move away from this individualistic approach that we've really been having and directing this to women on their own, and only focusing on that pregnancy period as the period to make a difference. And as you said, there's lots of great things out there in different stages, but I totally agree with you. More of that sort of integrated approach of how we could make a difference, I think could be really beneficial. I think that some of the things that you brought up today around the preconception space and pre-recognition really highlight for me the need for us to have much better access to reproductive healthcare in Australia. You would think a country such as ours that this would be a lot easier than it currently is for a lot of people. But I think, you know, these data that you've showed today really highlight this, that it's so important for people to have access to the reproductive healthcare that they want and need for those who aren't planning a pregnancy. And then for those who are planning a pregnancy, really thinking about how we can provide better information and supports around alcohol use during that preconception and early pregnancy period. And the other thing that's really highlighted today is for people who do continue to have challenges with alcohol use throughout pregnancy. And, you know, it's been such a privilege for us to work with many women through our clinic, and they describe a lot of barriers that they experience in terms of accessing care, you know, feeling unsafe to talk about their substance use, feeling afraid that their children will be removed if they discuss these issues, or even when they did ask for help, being told that they need to stop drinking without any referrals or supports being provided. So the data that you've presented today, you know, really highlight the need to better address these issues so women and pregnant people can have access to the supports that they need. And lastly, I just want to touch on, you know, how topical the last part of your talk is. I was really lucky to be in the US recently at their annual alcohol conference, and there were so many talks on co-exposure models, preclinical models, clinical studies. It was just a really hot topic. And it's something that's also so clinically relevant, you know, in reality, in a clinical context, we don't often see people who are using one substance only. It's often multiple substances. And we really don't have a good understanding about how these substances operate together. So I think what you're doing is really, really interesting and clinically relevant. And the last point with that is I think I would love for us to be involved in Australia in how we could capture more diverse samples in terms of these cohort studies, because a lot of the people that we work with clinically often come from low SES backgrounds. They're experiencing a wide range of complex environmental and health challenges. I know this is super tricky work to do, but it would be great to have these sort of cohort studies where we could have more inclusivity for those types of families as well.
Yeah, really important points, Natasha. Thank you. And I might pick up on your one point around, well, there's a question here from Fiona Cook around judgment and how to mitigate against sort of potentially inaccurate reporting of substance use because of that fear of judgment and how to do that in research. So I wonder, Delyse, if you might comment on how that was done in those cohorts.
Oh, look, it's such an important question, and we really, I know certainly in Triple B particularly, because it was a cohort that was focused on understanding substance use, we really put a lot of time and energy into this particular issue. Obviously, we can't control what people will or won't say, but we really tried to have a conversation with our participants who are coming into the study about things like confidentiality, that this, you know, when there's no judgment about this, that lots of women do use substances and we really want to understand about it. Your data will be protected. So being as honest as possible will really help us understand more about what women are experiencing. So sort of saying that up front, I guess we had also had really trained, experienced team to do our assessments. And I think that also helped because they were really comfortable and experienced in asking around very sensitive topics. And I think the other thing that's really important is obviously you know, establishing good empathy and a good connection when you're interviewing participants as well, that they don't feel judged. I think it's super important. And you know, it was something, as I said, we really did put a lot of time and effort into as a team to try as much as feasible. And we did a proportion of biological testing randomly in the sample as well. And we found really high concordance between the biological testing results and the self-report data. So we felt like as much as we could, we were getting fairly accurate data as much as we can sort of test that, if you like. But yeah, a lot of thought does need to be put into it when you're doing substance use research, I think, especially among pregnant people.
Right, thank you, Delyse. So I've got a number of questions here, so I'll get straight into those. Just around, particularly around the alcohol use in the periconception, was it possible to look at whether pregnancies were planned or unplanned, and if there was a difference there in prevalence of use?
I don't think we've looked at differences in prevalence of, like, in patterns of use relative to that, but certainly I would say I think we found that around 25% were unplanned. We haven't sort of looked differentially at patterns, but that would be a really good thing to look a little more closely at. But a lot of women were planning or trying, or they knew they might fall pregnant, but were still consuming alcohol or using other drugs. So it's interesting. It is a risk factor for substance use in that period. And as Natasha said, it's really important that we have reproductive support around that for people who don't want to fall pregnant. But we know that if you don't want to fall pregnant, you're much more likely to be using substances during that period because you don't think you're pregnant at all. But I was surprised, I think, that women who were intending to fall pregnant were still nonetheless using substances as much as they were during that period.
Yeah, I suppose you don't know how long they've been intending, and
Exactly.
could
Yeah.
drag out.
Some people intending can be a very long period.
Yeah. All right. And a question from Caitlin Burgess: did any of the studies explore reasons for continued alcohol use during pregnancy, or express anything around whether they were concerned about that use?
No, we didn't explore those things. I actually think we could do more work in that area, not necessarily unless it was retrospective, I guess, with our cohorts, but I think it would be a study that would be worthwhile doing, really exploring, particularly in terms of what it would tell us around prevention. I think it would be a valuable study of its own right.
And I had a question to pick up on your point, Delyse, around the timing of these cohorts. So they were all done at different times, and you followed the same cohorts for a long period of time. So the pregnancies were actually quite some time ago, if I understand correctly. Yeah, and varied between the cohorts.
The pregnancies varied a little between the cohorts. So the timing of the cohorts, obviously, they all started at different time points. So Vic started in adolescence. We started just prior to pregnancy in Triple B, and the ATP study started with the grandparents. So they've all sort of started at different time points. The actual pregnancy assessments were overlapping, if you like. So Triple B, it was around 2009 through to 2000, and when did we go through? It was 14, probably, when we finally wrapped up. We usually say 2013, around that period. And I know ATP was going a little longer than us, and VIX probably finished a bit before us, I think, with their pregnancy follow-up. So there was some overlap, even though they were at different times, but they were also in different states. The two longer studies were in Victoria. We recruited in Western Australia and New South Wales. So different samples, but consistent results.
Yeah, that was sort of my point. It's sort of reassuring, I suppose, to see the consistency and that it isn't that impacted by time or location. I guess that I'm wondering if there are similar cohorts now recruiting, and just so that there would be, because there's been a lot happen in that time around FASD awareness, vaping's now a thing, all of that. So just, what's happening in the future of this space?
In the future, well, I mean, the three cohorts I present on today are all continuing. So we've just finished a Life at 8 middle childhood follow-up, and have started our pilot for our Life at 15 follow-up because of the length of our follow-ups. They go for quite a few years. So we are assessing vaping in the children, so we'll be able to look a little more at that. But I know that a lot of these long-running studies are starting to have offspring studies. So what we're seeing is a continuation as the young person becomes a parent and they have children. Studies are continuing to follow them. So I think there's a lot of amazing data coming out that starts to have more of an intergenerational focus, and we can start to look across generations at some of these trends, which is really valuable. And I think in our newer cohorts, we bring in new topics as we go. So things like vaping, which were not even considered when we started Triple B, now are really, we're really comprehensively assessing those things in the offspring. So.
Yeah, brilliant. Oh, that makes me even more jealous.
Lots of good work to do, Alice.
Yes. Okay, so we have a question here from, forgive me if I don't pronounce your name correctly, but Tilahun Mossi, about maybe each of you could highlight a major research gap that you think that remains in the alcohol and cannabis use during the perinatal period field.
Oh, that's a tricky one. Major research gap. Oh, look, I guess probably the thing that jumps out to me most is, like, we did engage partners, and we have actually, I mean, we're still getting really good engagement. In fact, some partners who didn't participate during the early waves are now joining in the adolescent wave. So that's a great thing. Nonetheless, we just haven't been able to get as many partners as we would like, and it does result in a somewhat biased sample of partners. We would just love to do more father research. I think this, notion that's all about the mum is really quite flawed. Dads are so important, or partners, and obviously, relationships aren't just mums and dads anymore. They're so diverse now. We really could better capture that diversity, I think. But I'd love to see much more involvement from partners in research. I think that's a real gap that needs better addressing.
Yeah, that makes sense. And Natasha, what would your top pick be?
I would just love to see more studies where we have information about these different exposures together. So I thought it's awesome how Delyse has got information about multiple exposures and able to control for different exposures. A lot of the studies that you read don't do a good job of that. So we can't really understand what the effects of different exposures are. So I think, yeah, we need a lot of more research. And also, as we're talking about earlier, in diverse populations. So the levels of cannabis that you're going to see in one particular group compared to other groups are going to be really different. And obviously how much you're using is going to be a big thing in the adverse outcomes. So just, that diversity of the cohort and really getting that sort of information, I think, is going to be so valuable.
Yeah. Okay, thank you. We're running a little short on time, but I think we might be able to squeeze one or two more in. So just, I know, Delyse, that you're interested in childhood development as beyond that first, the neonatal outcomes. And there's a question here from an education learning specialist interested in what you might have seen in terms of delay in early learning among children whose parents smoked or drank and continued to do so during pregnancy.
Look, we haven't actually looked at that yet. We've really been focused on the perinatal data. It's been so rich to explore. But we do have data. Unfortunately, we didn't get our kind of early. We tried to get a preschool phase funded, and we didn't have a lot of success. It's really hard to keep these studies going, unfortunately. But we do our best, and we try our hardest. So we'll have more data on the middle childhood learning once we're cleaning that at the moment. So we'll be able to start looking at some of those things. We've also been collecting NAPLAN and other data external to the study as well, and we'll look to obviously get high school data as the children phase into that period. So we will have more on those kinds of outcomes coming.
Yeah, that sounds great.
It'll be really, it's really important. As a developmentalist, I'm kind of interested in diversity of developmental outcomes, and I think we know that educational outcomes are so important. So we'll definitely be exploring that area in the future.
Yeah, okay. And Natasha, I wonder if you have anything to add based on what you've seen in the clinic.
Yeah, so I mean, we can see effects on basically everything for someone who's had exposures during pregnancy. So a lot of people would have heard about a lot of the effects that can happen to the brain, but we've also been doing a lot of research here at UQ about the effects on the whole body due to alcohol as well. So we're really starting to understand FASD as more of a whole body condition than just a brain-based condition. So there's still a lot of work to be done, and that we need to understand about the different levels of the prenatal alcohol exposure and the variable effects, and yeah, the different effects of different substances together with the alcohol exposure as well. Yeah.
So much to do, so much data to collect. But we are sort of running out of time now, so I think I might have to call the question and answer time to a close. But there's a bunch of questions in there which I would love to pass on to you ladies, and there's a lot of compliments and a lot of thanks and gratitude for the great work. So we will endeavour to get those to you, because you should see all the nice things people say.
Thank you so much.
And just a massive thank you from us for the great presentation, and thank you, Natasha, for your insights as well. It's been a real pleasure to have you, and yeah, we'd be keen to hear about the developmental outcomes when that all comes. That's good.
Yep. Lots more webinars to do.
That's
Ella.
right. Right.
Thank you
All right.
so much. Thank you so much for the opportunity.
Thank you.
And I'd also like to thank the audience. Thank you for your participation, for your lovely questions and comments. As I say, we will pass those on. And before we bring the whole webinar to a close, I just want to highlight what we have coming up. So next week, we have Jodie Moller from the University of Wollongong speaking about the chemical content of e-cigarettes and how this has changed in response to evolving e-cigarette regulations in Australia. And to remind you, if you haven't registered already, that we have the NDARC Annual Research Symposium coming up on the 20th of September. You can see the details at the website there, but please do register. It's been popular and we're filling up. All right, I think that might be all for today. I hope you really enjoyed the session. I certainly did, and I look forward to seeing you again for the next NDARC webinar. Have a good afternoon, everyone.